Okay, so I think we're going to go ahead and get started. How can I see the chat box? Huh? How can I see the chat box? Will it pop up?
It'll send you notification.
Okay, all right. So I'm going to be talking today about delirium in the ICU. For those who don't know me, my name is Srikanth. I'm a PGY5. So just a little background, I finished EM residency here, did a year of ultrasound fellowship, and now in my first year of critical care. Excuse us, we're having some technical difficulties.
We have to re-download, or did you save it to a desktop?
Yeah, I did.
You just have to
Just restart it. Still sharing?
No, you're not. So share screen. Just start searching.
Okay.
Let's see if she's.
We're good?
Yeah, it should be.
Okay. So these are my objectives. I won't go through all of them, but we'll touch on these different aspects of delirium during the talk. So before I get started talking about delirium, I just want to preface it by saying SECM did recently put out an update to their guidelines in 2018. So this was an update to their 2013 PAD guidelines, and they added specifically 2 new topics, so rehabilitation and mobilization of sleep disruption. And what was unique about this is they also included patients as collaborators and authors. And these clinical practice guidelines were put out for the prevention and management of pain, agitation, sedation, delirium, immobility, and sleep disruption, PADIS guidelines. And they utilized A through F elements in your liberation bundle to implement these recommendations. They had various statements that were graded based on the amount of evidence behind it. The reason I bring this up is when we're specifically talking about delirium, I'll try to point out some of the guidelines that SECM put out specifically for delirium. And just so everyone's on the same page, when we talk about our ICU liberation bundle, specifically our A through F elements, this is what they're referring to. So your A element, assessing, preventing, and managing pain, your B element for your SATs and spontaneous breathing trials, your C element, your choice of analgesia and sedation, your D element for delirium, E for early mobility and exercise, and your F element, which is family engagement. And so delirium is a syndrome of multiple different etiologies. It's characterized specifically by a disturbance of consciousness with an associated change in cognition. Key features of it, really important, is its acute onset, tends to have a fluctuating course, and patients tend to have impaired short-term memory. And so there's multiple terms that are thrown around that a lot of times are referencing delirium. You may hear like acute confusional state, encephalopathy. Those are just a few terms. So I took this slide from SECM, and these are some of the different terms that could all be used to refer to delirium, just based on kind of the clinical picture that you're seeing with your patient, whether it's sundowning or altered mental status. Those different terms tend to have features all suggestive of delirium and could be used to reference delirium. So when we're talking about the epidemiology, the prevalence of delirium in an ICU setting is estimated at 32%. So almost 1 in 3 of patients that you take care of will have some type of delirium. But it also depends on your patient population and your ICU setting. So some studies have found that specifically in trauma burn patients that are mechanically ventilated, the prevalence of delirium can be high, upwards as 80% for multiple reasons. And as you talk about mechanically ventilated patient, the incidence of delirium tends to increase as well. And so why do we care about this? Well, numerous studies have shown that delirium is associated with prolonged hospitalization, increased mortality, and also an increased cost to our healthcare system. So when we're talking about long-term outcomes, one of the important long-term outcomes that we look at is specifically mortality. So here was a study that was published I think 10 years ago that looked at the number of days of ICU delirium and associated mortality, specifically in patients older than the age of 60. So the median duration of delirium in these patients was about 3 days, and their main outcome was 1 year mortality following discharge from the ICU. And they actually found some pretty significant evidence showing that the number of days of ICU delirium was significantly associated with time to death, like 1 year after admission. So this is a Kaplan-Meier curve, and you could see as the number of days increase as they go from 1 to 2 days to upwards of 5 days of delirium, the likelihood of having a worse outcome was much higher. ICU delirium has also been found to be an independent risk factor for the development of long-term cognitive impairment. So another study that was done was a prospective cohort study that specifically looked at mechanically ventilated patients. They assessed for delirium daily, and these patients underwent cognitive assessments at 3 and 12 months following discharge. And at 3 and 12 months following discharge, 79% and 71% respectively had some form of cognitive impairment. And so this was after they adjusted for age, pre-existing cognitive function, severity of illness, and exposure to sedative medications. So here's just a couple of figures from that same study, and you could see some statistical significance with number of days of ICU delirium with worsening performance at 3 and 12 months in terms of their long-term cognitive performance on some of these tests. So let's come up with some definitions for delirium. Again, there's multiple ways to define it. One of the most common ways is based on your DSM-5, which is kind of our most recent psychiatry guidelines that are out there. So delirium is defined specifically by 5 features. So first, in disturbance in attention and awareness. Secondly, it has to be acute and develops over a short period of time, and it generally tends to fluctuate during the day. It's a disturbance in cognition, and that can involve language, memory, disorientation. The fourth feature is that these disturbances are not better explained by a pre-existing or established neurocognitive disorder. So whether this is dementia or some pre-existing neurocognitive disorder that the patient has, and it also does not occur in the context of someone that is severely reduced in terms of their arousal, so someone that's in a coma. And then the last criteria is that the evidence from the history, physical, or lab, so essentially your entire clinical picture, suggests that the disturbance can be from a medical condition, substance intoxication or withdrawal, or from some type of medication. So you have a reason that kind of explains why this could be happening. So let's talk a little bit about subtypes. This might be something that we don't necessarily differentiate that much in the ICU. So you have hyperactive delirium, and this is your classic agitated, uncooperative patient, and many times they're combative. So these are the kind of patients where you're worried that there could be an acute safety concern, whether that's pulling out their ET tube or something else. These patients tend to have loud and fast speech. They tend to respond to internal stimuli, can be restless and wandering, and sometimes can appear intoxicated. So hypoactive delirium. So this is one that we don't necessarily see as much, especially isolated hypoactive delirium. Some features include poor memory and cognitive abilities. Patients may be somnolent, inattentive, or uninterested. They can have variable behavior, reduced amount and rate of speech. And this, again, is one that a lot of times is missed. It's one that you probably see more on the medical GPUs, especially in older patients, where sometimes they can have isolated hypoactive delirium. And at times, again, it's missed because there's not very many acute safety concerns for these patients. It can be subtle. And then finally mixed, which as the name suggests, includes features of both hyper and hypoactive. And this is actually your most common phenotype, accounting for almost 80% of cases. So when we talk specifically about these subtypes in the ICU setting, so the mixed subtype, this was a study that tried to classify your different subtypes and the prevalence in the ICU, and they found the mixed subtype was the most common, followed by hypoactive, and purely hyperactive was extremely rare in an ICU setting. The other thing that was interesting is they also found that patients that were age 65 and older tended to experience hypoactive delirium at a much greater rate than younger patients. So almost 40% versus 20%, and it was statistically significant. So again, something to keep in mind, older age is a strong predictor for hypoactive delirium. So especially your older patients that aren't mechanically ventilated, especially if there's like subtle changes in their behavior, consider hypoactive delirium in your differential. So next, I'm going to touch on the etiology behind delirium. So again, when you talk about delirium, it's a multifactorial etiology, and there's numerous factors that contribute to delirium. Predisposing conditions include older age, dementia, CNS disease, and alcohol abuse. So when we talk about risk factors, so one statement from the SECM guidelines is they do actually suggest that there are modifiable and non-modifiable risk factors for delirium. So this, again, the guidelines were based on, I think, almost 68 studies specifically looking at risk factors. And the modifiable ones that they highlight are benzodiazepine use and blood transfusions. The non-modifiable risk factors include greater age, dementia, prior coma, pre-ICU emergency surgery or trauma, and increasing Apache or ASA scores. They're all considered risk factors. So this table I pulled from UpToDate, and I won't go through all of these different potential causes, but you can see things like drugs and toxins, whether that's opiate medications or other drugs of abuse, infections, so from sepsis or any underlying infection, different metabolic derangements, whether someone is hypoxemic or hypercarbic. So brain disorders, organ failure, physical disorders. So pretty much anything and everything could lead to delirium. Almost like, I would say, almost every patient we see in the ICU probably fits into one of these categories at some point in their course. So next I want to touch a little bit on the pathophysiology. So again, the pathophysiology delirium is poorly understood, and there's numerous proposed mechanisms behind it. So the underlying hypothesis that's favored right now is that there's like an imbalance of different neurotransmitters, suggesting that there's decreased cholinergic activity along with increased dopaminergic activity, as well as increased or decreased serotonergic activity. And this kind of supports the evidence behind some of the management. Part of the reason why antipsychotics tend to be used frequently for delirium is they tend to target your neurotransmitter imbalance. There also is suggestion, again, of genetic predisposition for the development of delirium. And finally, as mentioned earlier, elderly and people with underlying CNS disease may have a heightened inflammatory response that could make them at increased risk for delirium. So I like this table just because it kind of pulls everything that we talked about together. So you have your risk factors for delirium, which we talked about, as well as your predisposing conditions, and then your pathophysiology. And you could see that patients sometimes who are older also have primed microglial cells that they say that put them at risk for delirium, and kind of all those things contribute and could lead to delirium. And so what about when we talk about diagnosis? So there are multiple validated tools used to detect delirium in critically ill patients. In fact, there was a study that talked about how a lot of cases of delirium can go undetected in the ICU when you're not using some type of clinical tool. And there's some evidence that ICU physicians recognize less than 1/3 of delirious critically ill patients when they're not using some type of instrument to aid in their diagnosis. And so here's some different tests or diagnostic tools that are available. I'm sure some of these you guys have heard about, like your CAM ICU score. There's the intensive care delirium screening checklist, another common one that's used, delirium detection score. So these are just different assessments, and they are all validated. Again, the most data that's out there is specifically for CAM ICU, which I'll kind of go through shortly. But different ICUs tend to use different ones. It's more of a system-wide process, kind of whatever your healthcare system tends to use. And so when we talk about CAM ICU, generally what it requires is two specific features. So feature one is it's acute onset and there's a fluctuating course. Feature two has to do with inattention, and they either need either a third feature or a fourth feature. So feature one and two plus some type of altered level of consciousness or disorganized thinking. And so it sounds kind of complicated, but if you look at the kind of an example of how they do it, and again, this is something that I think all of us should be able to do if you need to. So I'm just going to go through it quickly, but this is something that a lot of times our nurses do at the bedside, and you can find it in your flow sheet in Epic. It should tell you their CAM ICU score. So, you know, the first thing, whether or not there's some type of change in their fluctuating course or mental status. So if you answer no, then you're done there. Their CAM ICU is negative, there's no delirium. If you answer yes, you move on to box 2 and you try to assess for inattention. And there are some different ways you can have them do that. So asking them to squeeze your hand when you specifically say a letter, and you look at how many errors they have. So if they do this pretty well, so they don't have inattention, then they're also CAM ICU negative, so no delirium. So if they answer yes for 1 and 2, then you move on to 3 and you look at their level of consciousness. And the best way to do this is based on their RASS level, especially for mechanically ventilated patients. So if their RASS is something other than 0, whether that's -1 or -2, so they have some alteration in their level of consciousness, then they're CAM ICU positive and delirium's present. So if their RASS is 0, then you move on to the 4th box and you look to see whether or not there's some type of disorganized thinking. And again, some basic questions you ask, things like, are there, fish in a sea? Does 1 pound weigh more than 2? And depending on how many errors they have, so if they have multiple errors for this, then they would also be CAM ICU positive. So you can see it's not too complicated. It's something that we should be doing kind of daily on all of our ICU patients. So here's another diagnostic tool I wanted to point out. This is another one that's pretty common in an ICU setting, your intensive care delirium screening checklist, or your ICDSC, and it's based on 8 features. And again, a lot of times this is nursing driven. Patients get 1 point if any of those features are present. And if their score is 4 or greater, delirium is considered to be present. So this just shows some of your sensitivities and specificities for your checklist here. So CAM ICU, again, I wanted to give you guys a little bit of data behind some of the studies that have been done that have validated CAM ICU. So CAM ICU specifically has demonstrated pretty high accuracy, sensitivities from 93 to 100% and specificities of 98 to 100%, in the detection of delirium. There have been studies that have compared CAM ICU with your ICD-SC checklist. There was a prospective study done that looked at a little over 100 patients, and they found CAM ICU to have a little bit higher sensitivity, so 60 versus 40%, but lower specificity. There was another study that compared 3 of these different detection scores, and CAM ICU tended to have, again, a pretty good sensitivity of 80%, a higher specificity of 96%, compared to some of these other tools. You can see the delirium detection score did kind of poorly in terms of their sensitivity in this study. Again, there are some limitations when you're using a diagnostic tool, depending on what you use. You could just see with our CAM ICU that there's numerous sensitivities for the same instrument. A lot of this is also operator dependent. So there's evidence to suggest that if, providers that aren't experienced or don't really know how to apply it, that patients with delirium can go undiagnosed or even unrecognized. But overall, there's pretty good evidence that when delirium screening is applied part of your broader, ABCDEF bundle and protocol, that there's numerous clinical benefits that exist for patients, including shorter duration of mechanical ventilation, lower ICU stays, and decreased mortality. So kind of going back to our guidelines. So here's a good practice statement that was put out in the 2018 guidelines. So they do say that critically ill adults should be assessed for delirium, should be assessed regularly for delirium using a valid tool. And again, this is something that should be happening kind of daily in our ICUs. It tends to be nursing driven. So just when you're rounding, kind of just make sure, CAM ICU is done at least once a day, if not once a shift. The other thing I want to touch about when you're talking about diagnosis and detection of delirium is specifically your level of arousal and whether or not that can influence your detection of delirium. So another statement that they put out was your level of arousal may influence delirium assessments with a screening tool. And this data was based on 4 observational studies. So they looked at delirium assessment at different levels of wakefulness. So this included almost 2,700 patients, and a majority of these assessments involved CAM ICU, and they were specifically done in patients with a RASS of -2 to 0. And what was interesting is they found that patients with a RASS of -2 had almost a 77% positive delirium assessment versus 23% when they had a RASS of -1 or 0. And again, I think this becomes important when you're thinking about choosing a RASS target for your patients and understanding that, patients that tend to be more deeply sedated are going to be at higher risk for developing delirium. Patients with a RASS of -3 were deemed unable to assess, so they weren't able to even do an assessment on these patients. Another thing to point out is kind of differentiating coma versus delirium. So coma is defined by your level of arousal. So patients with a RASS of -4 or -5, so they're only responsive to physical or noxious stimuli, and they aren't able to communicate. So it's not to say that these patients, when their RASS is -5 and they aren't doing anything for you, aren't delirious. It's just that they, by definition, would be defined as being in a coma, so you're not able to even perform a delirium assessment. So they could still be delirious, and you won't know until you get them to an arousable level to participate in that screening. So that's why it's important that patients are only eligible for screening when they're arousable to verbal stimuli. And so they need to have a RASS of at least -3 or higher. And comatose patients should continually be reassessed over time to permit some type of delirium scoring. And again, there are some limitations with this. It's unclear whether a positive delirium assessment that results from sedation actually affects patient outcomes, or whether the sedation could be a confounder. So I think ultimately, you're going to need future studies that specifically look at the impact of delirium at different levels of arousal and whether or not this affects mortality or other clinically important outcomes. Okay, so for the last part of this talk, I'm going to focus on the management of delirium. So I kind of broke this up into non-pharmacological interventions and pharmacological interventions. So I'll start first with your non-pharmacological interventions. So these include things as simple as early mobility and rehabilitation, sleep enhancement, minimizing sedation and reducing unnecessary medications, reorienting your patients and maintaining adequate oxygenation, and pain management. Other things that have been found to help with the management of delirium include like constipation relief, nutrition and fluid replacement, sensory assist device. And so this specifically for your elderly patients that may have some underlying visual disturbances or, require hearing aids. So being able to get those to them when it's appropriate, so they're able to kind of process sensory better. And then cognitive stimulation, and this could be a wide variety of things to them. Probably the most common cognitive stimulation a lot of these studies looked at was just having a family member visit the patient and kind of be present to participate. So here's some evidence behind kind of early mobility and rehabilitation. So there was a study done in the Lancet in 2009 that looked at 104 mechanically ventilated patients, and they were randomized to either get early exercise and PTOT versus therapy as ordered by your primary team. And this was during periods of interruption in sedations. And their primary endpoint was return to independent functional status. And you could see the intervention group tended to do better. But the reason I put this up is their secondary endpoint was actually duration of delirium. And they found that the intervention group, the duration of delirium averaged to be about 2 days versus 4 days in your control. And you could also see just in your intervention group, they were tending to hit some of their milestones, including getting out of bed, transferring to a chair, ambulating much sooner than their control group, and with some statistical significance. Another important area that we talked about was delirium and sleep. So this kind of becomes like which one came first. So sleep deprivation can lead to delirium, and likewise sleep deprivation can be a manifestation of delirium. They're kind of interlinked. There's some different thoughts as to why this could be. Things such as loss of your day-night cues, environmental stimuli, pain, sedation, all are thought to contribute to sleep disruption. And another thing that I wanted to point out that is important to just keep in mind, that nighttime sedation doesn't necessarily promote sleep. I'm sure you guys, we've all worked nights where the titration of sedation isn't happening as aggressively as it would during the daytime because the patient is comfortable and sleeping. And just because they're sedated does not necessarily mean that they are sleeping. And so there's multiple studies that actually have utilized sleep promotion techniques and have tended to show a decreased level in the incidence of delirium. And this was one study that was done in 2014 that looked at different daytime and nighttime interventions. And so daytime interventions, including raising the blinds, avoiding daytime napping after a certain point, and nighttime interventions such as keeping the lights dim, trying to minimize alarms if you can, keeping the TV off. And they actually found a reduction in delirium incidence, so 49% versus 69% in their intervention group. So ultimately, based on kind of all this data, SECM, one of the statements they put out is, we suggest using a multi-component non-pharmacologic intervention that is focused on, but not limited to, reducing modifiable risk factors for delirium. So improving cognition and optimizing sleep, mobility, hearing, and vision in critically ill patients. So these multi-component interventions can include any strategy that helps shorten or decrease the duration of delirium, things such as reorientation, cognitive stimulation, different protocols that address your sedation, as well as, good sleep hygiene. Again, for this statement, they did say there's low quality evidence, but they did have 5 studies that included a little over 1,000 patients, and they found a pretty significant reduction in delirium in patients where a multimodal approach was applied. And use of these strategies not only reduced delirium, but also decreased your ICU length of stay. The other thing I want to touch on is your bundle implementation. So integrating your PADIS guidelines as well as your ABCDEF bundles have been associated with lower mortality and shorter ICU length of stays. So, and they found that strategies that target organizational changes have been associated with reduced mortality. And so I know this is something that we tend to do all the time during rounds, where we're constantly assessing, sedation, assessing delirium, but some studies have found where they do have like a nursing driven protocol where they actually go through your ABCDEF for every patient, tends to have higher bundle compliance rates. So just something to keep in mind if anyone's looking for a QI project. So there's many different multi-component implementation programs for ICU delirium assessment. And again, these programs that integrate your bundles have had the potential to potentially improve clinical outcomes. So here's just some evidence behind that. So there was a cohort study of a little over 6,000 patients. And during the study, they really had a focus on your F component, so like family engagement. And they found a pretty significant improvement in bundle compliance, which ultimately ended up resulting in more delirium-free days and reduced mortalities. So next I'm going to move on to some of the pharmacological management of delirium. And so I want to preface this by saying anytime you're thinking about treating a patient, let's say their CAM ICU is positive, so pharmacological management is primarily utilized when delirium is manifested by agitation and you have some concern for self-harm. And I'll kind of go into more detail on the next couple of slides. So, but when you are using pharmacological treatment, antipsychotics tend to be our mainstay of treatment. So either Haldol or atypical antipsychotics, your risperidones of quetiapine or Seroquel or olanzapine, those tends to be your most commonly used second generation. And then dexmedetomidine, which I'll talk about later, is also used for management. But again, there have been numerous studies done that look specifically at, first generation Haldol versus your second generation antipsychotics. And there's really been no good evidence to suggest that there's really any difference between the two of them in terms of management. So going back to our guidelines, so they suggest not using haloperidol, an atypical antipsychotic, ketamine, or any other drug to prevent delirium in critically ill patients. This was, again, some low quality evidence, but ultimately what they're getting at is it's recommended to not put someone on a medication to just prophylactically treat delirium. And going along those same lines, the next guideline along management is not routinely using haloperidol, atypical antipsychotic, or a statin to treat delirium. So again, there was low quality evidence is what they deemed this statement as, but they found no significant difference in terms of clinical outcomes. So patients that were routinely treated with an antipsychotic versus patients that weren't, there tended to really be no big difference in terms of days that they were mechanically ventilated or mortality. So kind of our big clinical endpoints that we think about. But it is important to keep in mind of some limitations with these studies. So most of these randomized clinical trials did utilize antipsychotic rescue medications in your placebo group. So specifically for agitation or hallucination. So there tends to be a little bit of a crossover in between your two groups. So I think ultimately the take home from that for me is that patients who are agitated and may be, acutely harmful to themselves or your staff, they may benefit from short-term use of pharmacological management. And I will touch on this as well. There is a little bit of evidence in one study that did show that atypical antipsychotics may potentially reduce the duration of delirium. So if you had to pick one, maybe quetiapine would be the drug of choice. So this was kind of what the previous statement was based on. So here's a couple of different clinical trials that were done that looked at antipsychotics in critically ill patients. I won't go through the first one because it talks about dex, but your second and fourth study, they really found no difference in terms of delirium incidence in your two groups. But in this study, they did find that the time to first resolution of delirium was a little bit shorter with quetiapine. So that was really the only study that showed some significant benefit with a second generation antipsychotic. But again, keep in mind, this was only 36 patients. So the last part about pharmacological management I want to touch on is dexmedetomidine. It's more and more common that we're seeing, especially part of our PAD protocol. So just a little background. So dex, it's a selective alpha-2 receptor agonist with sedative, analgesic, and sympatholytic properties. Patients sedated with dex tend to be more easily arousable compared to other agents and tend to have less respiratory depression. So multiple, I won't go through all the data behind this, but multiple randomized clinical trials have shown that dex is superior to benzodiazepines or morphine specifically for sedation. So again, part of the reason why benzos have tended to fall out of favor as being one of our first line agents for sedation. But they did also find that dex tended to have more combined delirium-free days as well as a shorter duration of delirium when compared to some other agents. And so this was another statement that SCCM put out where they suggest using dexmedetomidine for delirium in mechanically ventilated adults where agitation is precluding weaning or extubation. And so some of the evidence behind this, so there was a randomized trial that looked at dex versus a placebo for agitation that was precluding liberation from the ventilator in patients with delirium. And they had 71 patients. They did find a pretty significant increase in ventilator-free hours in the group that was being treated with Dex, the mean difference of about 17 hours. But there was no effect on ICU or hospital length of stay. So again, this was one of those weak recommendations that are out there, but something to consider if you have a delirious patient that you're having difficulty weaning from the ventilator. So kind of summarizing everything we've talked about today. So when you encounter a delirious patient in the ICU, or you're rounding on them and they tell you that their CAM-ICU is positive, kind of here's a stepwise approach for how to think about delirium. And I got this from SECM. And so the first thing, they kind of divide it up into 3 steps. So the first step is they say stop. So you kind of stop, take a step back, and consider the big picture. So what are all the medications the patient may be on? Did they recently receive any sedatives or benzodiazepines? Keep in mind, what the patient's renal function is, and renally adjust doses as needed, and plan for sedation holidays and your spontaneous awakening trials. The second step would be think. And so they kind of divide that up into your T being toxic situations, whether that's some new shock or toxin, H being hypoxemia, infection, kind of all the different things we touched on in etiology for delirium. So is this someone who's becoming septic and it's now manifesting as delirium, and I need to be, treating them with antibiotics and managing their sepsis, or, thinking big picture etiology wise. And kind of the last step would be medication. So again, kind of my take home point from all this is just because someone has a positive CAM-ICU score or they're screening positive for delirium doesn't necessarily mean you jump to medication. That tends to be kind of the last step on your algorithm. And really the biggest indication for medical management of these patients is when there is acute agitation or risk for self-harm. So things we talked about when you're worried they're going to potentially self-extubate or pull out lines or cause harm to themselves, then obviously pharmacological management is definitely indicated. And as we talked about, atypical antipsychotics may potentially, specifically quetiapine, reduce the duration of delirium, and Dex is preferred to benzos. So the last couple minutes, I just want to touch a little bit on COVID-19 and delirium since it's an ongoing pandemic. So COVID-19, there was a recent multi-center cohort study that looked at the prevalence of delirium in patients that were admitted to the ICU with COVID-19. So this was just published, I think, 2 months ago. It was actually a pretty extensive study. They included a little over 2,000 patients from 69 ICUs across 14 countries. And they found that almost 67% were mechanically ventilated when they were initially admitted to the ICU, and 88% required some form of mechanical ventilation at some point during their hospitalization. Other important characteristics, so 64% of patients were given benzos for a median of 7 days, and 71% were given propofol for a median duration of 7 days as well. Also important, their median RASS score tended to be -4 while they were on mechanical ventilation. So they ended up finding that almost 80% of patients were comatose for an average of 10 days, and 55% were delirious for a median of 3 days. Some factors they found that were associated with higher risk of delirium, kind of things that were all expected. So being mechanically ventilated, restraints, benzo use, being on vasopressors, and antipsychotics. And another thing that they found was specifically family visitation, whether it was in person or virtual, was associated with a lower risk of delirium to some pretty significant statistical significance. So this is just a little plot that looks at some of the differences between these patients. And you can see on this side, we're seeing things that were more protective for delirium, and the big one was family visitation, and things higher risk of delirium. Obviously, the big ones, your sedative infusion, restraints, vasopressors, and then being mechanically ventilated, and obviously age. So I guess in terms of limitations of the study, the authors do mention that, you know, there was multiple different ICUs, so there's some variability between your ICUs, but multiple ICUs were operating in resource constrained environments. And so, as you could imagine, some of the things that are part of our bundles, things like, you know, utilizing light sedation, spontaneous awakening breathing trials, avoiding benzos, early mobility, all of those things occurred on fewer than 1 in every 3 patients, in patients who had COVID and had severe infection. They also found that delirium and coma were common in mechanically ventilated COVID patients and often lasted twice as long when compared to your general ICU patients. And I think we have some pretty good reasons for why some of that would be. Obviously not being able to do family visitation, plus or minus how deeply sedated some of these patients had to be to maintain their vent mechanics, probably all contribute to this. And obviously delirium is probably lower on your list of things that you're concerned about in the acute setting, but I think it is important to keep that in mind, especially when we are managing these patients. So the risk tended to be lower in patients when we were avoiding benzosedative infusions, as well as when family engagement was present, and also try the best we can to implement the same ABCDEF strategies we do on our general ICU patients to COVID patients as well. So kind of the big take-home points from today. So delirium is pretty common in an ICU setting, and days of being delirious are associated with long-term cognitive impairment and mortality. Ultimately, utilizing a multimodal approach in the management of delirium to promote recovery can improve outcomes. So, you know, doing things like treating pain first, trying to do your spontaneous breathing trials, minimizing sedation, increasing mobility, you know, really utilizing patient family participation to the best we can, and then kind of remembering our bundle approach. So that's all I have. Take any questions.
Hi, Akshay. Can you hear me?
Yeah, I can hear you.
Hi, this is Riyad Ramadan from the Neuro ICU. Thank you for an excellent presentation. This was really well put together. I just had from the Neuro ICU sort of perspective. I also just want to make a comment, to just keep a close eye on the possibility for delirious patients to have seizures and specifically non-convulsive seizures and status is something that we see very commonly in patients, not only the neurologically affected patients or the ones with a brain injury, but also in the common and more general ICU population. Think about 8 to 10% of patients, end up having non-convulsive seizures or status as an actual cause of their delirium, and that is also associated with, obviously longer hospital stays and mortality rate. I think in if you put those patients on continuous EEG, and I'm talking about those elderly, 65 years of age. There was a small cohort of patients. Think about like 70 patients or so. They actually detected seizures on a continuous EEG in up to almost 30% of those patients. So just to keep in mind, in your approach to diagnosing, or managing delirium, that seizures is not uncommon in general ICU population, including the MICU.
Yeah, thank you. No, that is very helpful. I think it's a good teaching point as well. Obviously, if someone is testing positive on their ICU delirium screening, keeping a broad differential, maybe it's like you said, subclinical status or something else going on that could be explaining their symptoms. So, yeah.
One of the points I'll make for you guys as well is you mentioned hyperactive delirium. I think it's really under-recognized, and you actually increase mortality with compared to your hyperactive delirium. It can tend to be pretty obvious, whereas hyperactive delirium can be a little more subtle. Being cognizant of those patients are super important, and making sure we treat it, whether it be non-pharmacological methods or the pharmacological methods. Two, especially if you get the spells in the ICU, right? Your residents might not be as keen to some of the learning things, so it's not as sexy as the really kind of related stuff, but this makes a huge difference for the mortality. And these are small things, just like the ABC ones, right? The lines, the bullies. So I would, as part of your workflow, make sure you're either look at your KMSU scores or reviewing your patients to see if that's going on, because those small things, small interventions of recognizing and treating them can make a long-term difference for your patients. Just as part of your workflow, I highly recommend doing that. Running more.
I just had a quick,
Yeah.
out of curiosity, in that delirium COVID, when they broke down when they said to the family, did they break down the virtual versus in-person visits? And was there any difference in those? Do you know if they did?
I did not see that. No, I didn't see if they broke it down, but that's a good question, because I know we were doing a lot of virtual thing, but hopefully with like vaccination efforts ramping up, they can start to do some maybe in person. Who knows?
Just curious.
Yeah.
Two questions. So for delirium, about seizures, probably delirium from chemical these patients that can be still low, but like treat as though it's epilepsy, or you resolve the delirium, like does the treatment not just help?
So I guess if they do have, obviously, like if their EEG is, so the question for people who couldn't hear is patients that are not, so if they are having signs of delirium but are actually, having subclinical seizures, would we load them with anti-epileptics? And the answer would be if you have evidence to suggest that they are having seizures, whether it's via an EEG or something else, then I would say yes. Probably not every patient that is scoring positive. I don't think there's really evidence that we would treat them empirically for seizures, but I do think that unless it's like high in your differential or they have some type of structural brain abnormality or other risk factors that would put them at risk for it, or if they have an underlying seizure disorder, then maybe it might be indicated to treat them.
And then if they are resolved, right, it's not something that continue to just stop it due to the delirium, right? Or that's because we can hear epilepsy, or is this just problem by disintegration and they don't require it after they're
That I'm not sure. I don't know if one of the neuro intensivists like Dr. Ramadan want to chime in. The question is, if these patients, you end up treating them for seizures with an AED and they end up having a positive EEG and they were having subclinical seizures, would you continue them on long-term management with anti-epileptics even if their delirium has resolved?
So my question is, doesn't that sort of go against this that you were probably talking about? Are we trying to do like issues that are at our ICU, or are we still connected to the deep sedation?
So I'm going to open this question up because I'm not really sure. The question was, with our COVID policy, are we still doing deep sedation on severe COVID patients to prevent self-extubation? And if we are, doesn't that lead to more delirium?
I can't speak to the actual policy in the sense that, so when we did have a lot of people a lot of observations, no one full well we read the long-term risk of increased delirium, but at the same time, we also noticed a lot of bad outcomes of observations. Also, lesser two evils at that point. Now with the lower volumes and the fact that it's a little bit more going on, we revisit it and also revisit it
I mean, is there a formal policy that these patients you're titrating to like a higher, like a lower RAS, like a RAS of -3 or -4? Because I was not doing that. Like, what?
Yeah, that's what I was like,
Yeah, we should probably revisit that. I don't know.
yeah, I think so.
Seems like,
At least right now, I know, like, we're not doing anything to the particular, like, we're
yeah, I mean, I think, again, if you're proning them and doing other stuff, you don't really have a choice, right? Like you're titrating to meet your endpoints. But if it's someone who you're weaning from the ventilator just because they have COVID, I can't think of any reason why they would need to have such a high sedation target. So, okay, thank you.